has one of the largest numbers of people living with HIV in sub-Saharan Africa and the joint third largest HIV epidemic in the world. While Kenya has seen a progressive decline in HIV prevalence among adults, prevalence continues to remain high among key populations, which include female sex workers, FSW, men who have sex with men, MSM, people who inject drugs, PWED, and transgender people. These populations also have the least access to prevention and treatment services because their behavior is often stigmatized and criminalized. They are a priority population in the HIV response. Reliable KPSE data is essential to program managers, policymakers, funders, researchers, KP networks, and implementers in making assessments of the resources and capacity needed to deliver HIV services to the population. Kenya has stressed the importance of scaling up high-impact interventions in prioritized geographical locations and populations at higher risk of HIV infection since 2014. Considering the fact that KP size estimates fluctuate due to entrance of new KPs, change in behaviors, closure in existing sites, and the emergence of new ones, it's good practice to conduct remapping and estimation every 4 to 5 years. In line with this good practice, Kenya conducted several remapping and KP size estimation exercises between 2017 and 2020.
For the Kenyan context, the government, or rather NASCOP, which is the National AIDS and STI Control Program, it leads the programs here for HIV in terms of interventions and service delivery. There was KPSE 1, which is Key Population Size Estimates Phase 1, which focused mostly on mapping and enumeration.
KPSE Phase 1 was done in 2017 to 2018 in 35 counties, where KP programs were already being implemented using a programmatic mapping approach. This first phase was done in collaboration with implementing partners with a full participation of peer educators and outreach workers in those counties. In the first stage, with the help of KP implementers, especially peer educators and outreach workers, a line list of all physical sites where KP individuals solicit clients, conduct sex work, cruise, meet other sexual partners, or inject drugs was developed. In Kenya, the sites where FSW, MSM, and PWED congregate are different, hence separate lists for subpopulations were made. At the second stage, the peer educators and outreach workers visited each of those sites and validated the existence of the site. If the site was closed or renamed, it was noted. All the sites that were open and active, the peer educators and outreach workers conducted a focus group discussion with KPs in the site and other key informants like managers or servers if it was a bar to understand the operational timings of the site, days with higher clientele or KP visiting the site, and the estimated number of KPs who visit the site on a normal day and on a busy day. During the discussion, the key informants were also asked if transgender people visited the site, and if so, their size was also estimated. The informants were also asked about new sites that have emerged, and if new sites were named, the site was added to the master list, visited, and a similar discussion was conducted to characterize the site and estimate the population.
We have tried to understand in each county under the locations under the implementation partner, how many venues, how many locations they were working in. Consultation was done with the other peer educators and the key populations in the implementing partners cohort to understand if there are new hotspots that have emerged or some old hotspots that have been closed.
Once the data was collected, it was presented to the national stakeholders and county stakeholders through the Key Population Committee of Experts. The stakeholders provided feedback, and based on the feedback, in few counties, NASCOP had to go back to the implementers and redo the exercise if needed. The estimates were then finalized through a county and national consensus building process. This exercise provided size estimates for FSW, MSM, PWED, and transgender populations in 35 counties. As a follow-up to KPSE 1, Kenya also conducted virtual mapping and size estimation for MSM to map and estimate the MSM who seek partners in the virtual spaces and who may not visit the physical sites. Virtual mapping was conducted in 3 counties to estimate the MSM population missed out of mapping and estimation exercises in physical sites. It was estimated that 25% of the MSM in these 3 counties do not visit physical sites and exclusively meet partners through virtual sites. Hence, the technical team recommended adding 25% to the estimates of MSM derived through KPSE 1. However, the country needed KP size estimation for 47 counties, and hence KPSE Phase 2 was conducted in 2019 to validate the findings of KPSE 1 and use the findings to model and estimate for remaining counties where KPSE 2 was not done. For primary data collection, 5 urban counties and 2 rural counties in Kenya were randomly selected, and multiple methods were used to generate estimates. These methods included unique object distribution, unique event multipliers, and 3-step capture-recapture.
And so when they come in, we're checking several things, and this is where the capture-recapture comes in. Your first capture, did you receive a unique object? Yes, no. Can you show it to me? So we confirm we found you on the first one, or if you don't have it, what did it look like? Where did you get it? So we want to make sure that you actually we captured you on the first one. And then did you attend an event, say at this hotel on this day? So we are trying to see if you recall attending an event, what was it about? So we confirm you got captured on the second one. And finally, obviously, we captured you on the third one, which is you showing up to the MINI-RDS interview.
For the unique object distribution method, a unique object is distributed to the target population 2 to 4 weeks before unique events are held. In this case, a bracelet labeled diversity was used as a unique object. The unique object was distributed among KP members in selected hotspots, which included streets, bars, clubs, brothels, hotels or lodges, and dens. The KP members who received the objects were asked to keep them for at least 3 months and not give them to anyone else. This was soon followed by the unique event multipliers, which were publicized planned initiatives designed to bring KP groups together in the selected counties. All the people attending these events were counted and asked a set of questions upon entry about the unique object. Had they received it? If they could describe what the person who gave it to them was wearing, could they show it? Could they identify it from a set of photos? Mini-respondent-driven sampling, or MINI-RDS, was used in the 3-step capture-recapture method. In this case, coupons are used to recruit the KP of interest. The coupons are distributed to seeds. These are members of the KP community or people who regularly interact with the community. Once the coupons are distributed to the seeds, they hand them out to their peers, who are then directed to a physical location where they can be interviewed. After the KPSE 2 estimates for all 47 counties were available, the KP program conducted National KP Committee of Experts (COE) meetings and County KP COE meetings to validate the estimates. In 36 counties where counties had data from KPSE 1 and KPSE 2, they compared the 2 data and chose the one which was closer to reality based on their wisdom and experience of implementing KP programs. Through this consensus process, the KPSE 2 size estimates were finalized and published. As KPSE 2 did not include estimates of transgender people, the country used the KPSE 1 transgender people estimates as national estimates. Strong partnerships are a key component of the size estimation exercises. Various partners have been involved in these mapping and estimation exercises. KPSE is done under the leadership of the Ministry of Health through the division of NASCOP and the national level. At the county level, the County Ministry of Health, especially the county and sub-county AIDS control coordinators, play a key role. PEPFAR funded most of these past exercises, and Global Fund supported implementation and data collection in several counties. University of Manitoba and the University of California, San Francisco provide technical support in design, implementation, analysis, and report writing, while the International AIDS Vaccine Initiative supported the documentation of KPSE as a best practice for Africa. The implementing partners, especially the peer educators and outreach workers, collected data in Phase 1 and facilitated the collection of data during KPSE 2. The KP networks provided technical and supervisory support in conducting these activities. Other stakeholders played a key role during the various technical and committee of experts meeting by providing feedback.
Before the KPSE came in, we had an idea of key population in the country, but we could not quantify, and so we could not gauge how far we needed to go, how much effort we needed to put to get people on key population prevention package of care.
I think that's a unique area that Kenya has been able to spearhead as one of the best practices. So national estimates really help you to come up with the national targets. They're able to help you to know whether you're targeting right as a country. So I believe that size estimation should actually be used as an advocacy tool for allocation of resources. Kenya has been able to use our size estimation reports to allocate resources either from domestic sources or from the funding. That was not the story 10 years ago when we didn't have the size estimate. So it has been a game changer for the country.